So Dr. Sivakumar spoke about, how do you get good outcomes. So I'm just showing you a structured tool which we have. This is about, we are talking about the effectiveness part. When this the pyramid we saw earlier. So whatever we are talking is about effectiveness, which is about how do we minimize complication, how do we maximize the visual outcome. So some of the values which drive the effectiveness is the quality of your resources, the microscope, the phaco machine, the surgical instruments, the sterilization, all of that. Then how do you adopt evidence-based practices? And equally important is the training of your HR, which means the doctors, nurses. And equally, the most important is monitoring the outcome. So if you don't monitor, then you cannot learn from that. So we have created a software tool called Cataract Surgery Outcome Monitoring Tool. So here, earlier we used to enter all the data manually. Now it's all entered through from the EMR, and we have a way of data verification, data confirmation, and then once it goes into an Excel sheet, from that it comes into this particular thing. And what are the things we monitor? We monitor everything like pre-operative, the surgical, the post-operative, the follow-up, and also the endophthalmitis. The most important, I've colored it like intraoperative complication rate, the resurgeries, the follow-up uncorrected visual acuity, follow-up best corrected visual acuity, the spherical equivalent to make sure that the biometry is done well. So, and this is basically how it looks like. Like when you look at the pre-operative data, we are looking at how many patients have come with advanced cataract in the surgery. It's like 2.4%. And then what is the number of patients with vision less than 6/60, what is the percentage? So all of that, like I was telling earlier, and this is a long list. So like intraoperative complications and post-operative complication. So, and resurgeries. And the immediate post-operatively, the period, what is the visual acuity the patients have, the follow-up advice. So it's a long list, follow-up examination, how many patients actually came for follow-up, what is the vision at that point, uncorrected, miscorrected, was there any complication during that point, and what is the spherical equivalent, looking at the thing. So this is basically the tool as I wanted to show it. So anyway, what do you do with this information? You have a lot of information. So we have weekly review meetings. What do we review actually in this meeting? We look at the patients who had surgical complications, patients who had a post-operative surgical complication, patients who had resurgery. So when there's a complication, why did that complication happen? Is there anything we could have done to avoid that complication? Okay, the complication has happened. Was it managed well? And what is the outcome of that complication? Did the patient again need a resurgery, or the patient went back home well? And what was the visual acuity they got? Was there any patient who came back with an infection during that period? Was there the patients who had, the 2 months back they were operated, and those patients, what is the visual acuity level? So all of that will use this information. And about matching the complexity and with the competence Dr. Sivakumar mentioned. So we based, as a routine, as you can see here, this is our EMR. We divide them into group 1, group 2, group 3 based on this. So all the hard cataract, mature cataract, like high myopia, high hypermetropia, post-trabeculectomy, all of that becomes a group 2 or a complex surgery, we call it. So and the group 3 is the one which have like subluxated cataract, post-VR cataract, post-injection cataract, and phacolytic. I mean, like the group 1 anybody can do. Group 2 it has to be done by an experienced surgeon. Group 3 it has to be done by the senior most surgeon. And we also mandate that the group 3 the doctor should see before they operate. Otherwise, rest of the cases, the nurses decide whom will operate that. We also make sure that this also helps in getting the guarded visual prognosis from the patient. We are also able to prepare them pre-operatively so that we can minimize the complications. So all of this really helps. And again, we also focus on the surgical training. We in our system, we make the trainees or postgraduates or the fellows competent within 12 months to operate independently. So that is how now we are able to also maintain quality. But in the 12 months, they really do adequate number, at least 40 to 50 surgeries to make them independent. And we also have set a goal of every postgraduate doing at least 300 surgeries, because we had seen only when they cross 300 surgeries, the complication rate also drops below 2%. So we have those numbers and we also implement that. And for the first 150 cases, we have Oscar scoring as well. And again, one point of time, initially the first year, second year, any complication happens for a trainee, it has to be managed by a senior surgeon. But when they come to the third year, they are also given a CME on how they can manage by themselves. And they also get an opportunity to be a trainer for the next batch of doctors. So when they become a trainer and train the next batch, they also become even more competent. So they really understand what it means to teach. So all of this helps to make the doctors better. And again, we track the follow-up uncorrected visual acuity, as he said. So we look at, the first line is uncorrected vision of here, I'm not able to, so uncorrected vision of 6/6. The second bar is the patients who had a 6/9 and 6/6. The third bar is 6/12, 6/9, 6/6. And 6/18 means, all those who had 6/18 and better. So these are all uncorrected vision. And we have set a goal of, at least 6/18 or better should be 95% in phaco and 85% in manual small incision surgery. So, and again, for this to work, we also should have an accurate biometry. So here again, we track the spherical equivalent. We would like to see that, if it is optical biometry is used, the 0.5 diopter error should be more than 90%. If it is a ultrasonic biometer, contact means it should be more than 85%. So we also have certain benchmarks. And not only that, for each individual refractionist or biometrists who do the biometry, we also generate a list to see if there is any particular error in that particular person as well. So we have been tracking all these outcomes for the last, since 2011, 2012. And we had published in the year 2021 of the outcomes of about 6 years of about 1.86 million patients in the eye journal. So I'm just sharing that. During this period, we have done about 577,000 cases or 5.7 lakh phacoemulsification procedures. And we were able to show that there is a reduction in the complication rate from 1.3% to 0.7%, while the re-surgery level remained the same. And again, when we had done about 1.24 million manual small incision, here the complication rate has dropped from 1.8% to 1.3%. And again, the re-operation rate did not change. Then we also look at the uncorrected visual acuity. The uncorrected visual acuity in manual small incision surgery of vision, of uncorrected vision of 6/18 or better, improved from 66% to 85%. A lot of that is because the way they change the incision, but also the way the refractionists do the refraction. When we know that we are giving importance for the uncorrected vision, they also document it in the proper way. So otherwise they may not also do a good job about that. We also noticed from the data that the patient who had a poor visual outcome of less than 6/60 at 1 month follow-up again dropped from 2.5% to 1.7%. So I'm sharing all this data. So this may be a big data, but your own practice, if you have, like Dr. Sivakumar said, you can even document all of that and even in an Excel sheet. Now, if you do it, then there are now AI tools are available. You'll be able to get a good report out of that. So, and again, last year we also looked at and published it in the year 2025. Now, we looked at almost like 12-year data of similar thing. When we looked at the post-operative mean visual acuity, what is the vision that has happened. I'm going to show you 4 graphs. The first graph, you see in the bottom, the vision on the top is poor, the vision in the bottom is better. Okay, this is 6/24, 6/18 and all that here, and we have 6/6 here. And this is a phaco. If you look at the best corrected visual acuity from 2012 to 23, it has not changed much. The best corrected visual acuity remains the same. And if you look at the uncorrected vision in phaco, there has been a marginal improvement. It used to be between 6/12 and 6/9. has become better. It is now between 6/9 and 6/7.5. So there has been an increase. So this kind of subtle improvement you can see only on a long-term basis. The small incision best corrected visual acuity again has improved. Reasonably from 6/9 it has come between 6/7 to 6/6. And what is interesting is the uncorrected visual acuity. So which used to be like 6/24 has become now, it is come close to 6/15. So I mean all this data is important. If you collect the data, you can look at it. So another interesting thing about this tool is we can also know the patients whose vision has not improved. For example, these are the patients who we have taken for surgery when their preoperative vision is 6/12. And post-operatively, what has happened to this patient? How many of these, whoever is on red, the vision is poor. So these are all data which were recorded between 8 days to 45 days. Some of these would have become better after some point of time. But you can have a record of that. For here, the vision has improved in almost 96% of the cases, not changed in 3%. It has deteriorated 1.38%. But we have a tool to extract the particular patients where the vision has become deteriorated, and we can also look at, see and analyze what has happened to these patients. So just to conclude, now when these data, what I'm showing is the doctors can see. The individual doctor will be able to log in and see what is the data, how he has done from, if he has done a 3-year fellowship or a 3-year residency, he'll be able to see all the data from the beginning. And that he also will be able to benchmark himself with another doctor, another postgraduate. He can compare himself, if he has done about 500 surgeries, he can compare himself with somebody who had done a 500 surgery or 5,000 surgeries, just to compare himself, where he stands. The data gives what is the average data and what is the best data as well. And we also were able to show that the incision architecture matters in manual SICS. And this also helps to minimize the complication, understand the cause for the poor vision. And we also were able to change the A constant of at least one IOL, where we found that this IOL, with that A constant, we were consistently getting hypermetropic refractive error, and we were able to find that and change it. These are all not possible if you don't do that. So, the overall, whatever way, what the whole purpose of this is to share some of our best practices, and also to share with you that the concept that you have to track in some way or the other, so that you can make a change in your practice, so that the patients can become better. Just going back to the first slide. So any organization, any practitioner would like to see the volume of these patients coming to them increases year by year. And if you are able to make sure that the quality, the clinical quality, and the the service quality, as Dr. Venkatesh mentioned, not just the patient, but also the attendants. If you are able to address that, definitely you will see increase in the volume of patient coming to you year after year. Thank you. So we can take any questions, anything, comments, or anything you want to share from your own practice. Anything you want to add, Venkatesh, as like final remarks?
The safety is a mindset. Like Haripriya was beautifully saying, it's very, very difficult to get that sometimes into the team. So especially encouraging them to report the near misses, because that is more important. So once you get those near miss or the touch points where in the last minute they found something and corrected it, then we can really analyze why this has happened. So they say that for every incident or a sentinel event, there would have been thousands of near miss, like how we know in accidents, right? In that particular place, we would have escaped 1,000 times. And one fine day, we may have an accident. It's like a wet floor. There will be thousands of people walking, but one fine day, somebody would slip and fall. But can I prevent that wet floor? Looking at that is so important. If somebody has slipped but not had an injury, they should be reporting it. Not when the injury really happens. Like for example, last week, there was a fire nozzle where a young kid, I don't know, the kid was playing, went under the nozzle, and then he had an injury here, which we had to suture. Can we look into that? There are several times near misses would have happened, or some would have gone, not had an injury, but how do you recognize all that? Is by reporting. So if you have a mechanism of reporting those incidents, we do online, anybody can do, but it's more important that it's anonymous, right? So we're not going to blame anybody. So the team have to understand that it is not to do a blame game, it is to find and solve for the future, or resolve for that it should never happen. So I think that's the more important part in that safety message, getting those early problems into picture so that you don't have a bigger problem coming up.
Anything, Sir Kumar?
And so when we are looking at good outcomes, we generally tend to look at only good surgery and other things. But what I wanted to highlight basically is that there's a lot of planning which goes into it. There's a lot of teamwork that goes into it. And it is not just the surgeon alone, but the team surrounding him, but also which should be very tuned to doing good quality work. So anybody who is defaulting on that, the quality of surgery can go down. So it's very important to build a team which is very, very passionate about quality, and they should know about all this. It's very essential to attune to them, saying that it's not only the surgeon's surgery which is going to be a deciding factor for good outcomes, but these are the various things, right from the preoperative examination to the biometry to the post-operative care. So when this is brought into the consciousness of the team, automatically the team will be oriented towards working. Otherwise, the team doesn't know that, it's doing good work. And that is why also analyzing the data, collecting the data and analyzing is important. It's not only we surgeons who know how well we are doing, but the biometrists know how well they are doing, and they are pushing pushing themselves forward for more accuracy. So it helps us in another way to make everyone aware about the reports, about the details. So quality is something which is, the outcomes at least, has to have some wholesome inputs for very good quality. So this is what I wanted to.
Thanks. Any other comments, Venkatesh?
Any questions?
Any questions?
Yes, Abdul.
For a small practice or a small trust hospital, of course, Arvind is a big system, actually. What matters most, as we said, the teamwork. So the staff has to be provided psychological security. The staff has to be provided psychological security that if they bring out any issue, they won't be judged, and the doctor or whoever is in charge would look at that from a systematic issue or a systematic problem. And it won't be possible to, stop everything. Idiosyncratic problems like a child hitting one somewhere. But of course, we can put those problems into systematic buckets and, see if we can solve them. So providing staff with psychological security that the job is protected, even if they bring in some adverse events or something, that has to be there. Unless until we take care of that, they don't bring out the issues actually.
I think that's a brilliant point. I think if you bring that kind of a systems approach in some of these things which happen, let's say that there is a cable here. So the systems approach here is to put a sticker on top of it, right? This didn't happen several years back. So some people would drip, the cable would fall, or the mic would fall, or the person itself would fall. I've seen Malaravan falling in one of the APAOs in Bangkok. So things can happen, no? So how do you systematically solve this? So this is a systematic solution. Just now we were seeing in a coffee area, near that coffee area, I don't know where we have a mat, but the mat is lifted on one side. I'm sure many of you. So that at least 3-4 people I saw when I just had a tea there. So now we'll have to fix it. So I think it's like that. So your staff has to understand that you are just raising this alarm for us to systematically solve this, not to find blame on you or somebody else.
Okay, thanks, Venkatesh. I just want to close with one remark. So, go ahead.
I see a lot of inertia in using AMR even the staff, the nurses, the paramedical, and sometimes even the doctors, how to push it and how to go ahead at all levels.
Yeah,
It's a
correct.
very challenging.
It's challenging, yeah. So we also have a EMR, we also have the same problem. Some of the things you have to mandate, having a rule engine to make sure that the data, if it is not entered, you cannot go to the next. So you cannot do it for everything, but there are certain areas where the doctors may not be interested to enter the data. Is there a paramedical person can do that job, you can see. Like entering the compliance, systemic medication, systemic thing, all of that, you have to find a alternate way where the doctors may not be interested to enter the data. So whereas the paramedics will enter all the data, the doctors, but like an anti-segment finding, all that, they have to do it. But we also slowly have to move towards documentation, digital documentation, taking photograph of the anterior segment of the eye or posterior segment of the eye. Maybe there are some of the ways we may have to systematize so that we are able to generate data from that rather than from the doctor's thing. But I just want to conclude by saying that, the AI is coming in a big way in medicine, in healthcare, and also ophthalmology is no exception. And soon, the gap of the clinical knowledge or the clinical skill or the surgical skill is going to become very, very narrow between providers. Today, that is what is differentiating somebody's practice. When the AI tools all come, that will go away. What will remain is what is the experience you are going to give to your patients when they come to your facility. That experience is going to be very, very important. And again, when I talk about AI is useless if there are no data. So like EMR, if you don't put data, sometimes you may think this is useless data for me to make a decision today, but that may be the most important data if you want to really exploit the potential of AI. So don't neglect any data. Anything about the patient is suffering, whatever he had a fall, he had taken this, taken that surgery, everything should be there. Otherwise, you may not know what is really happening to or you may not get the full benefit out of the AI. So really a complete documentation of the patient is very important. A digital documentation of the anterior segment findings, posterior segment findings, and many other equipment, whatever that we are able to input into the EMR, we should do it. So that's a way, and again, giving the patient a good experience is also important. I really would like to thank all of you for coming in good numbers, staying all through this 1 hour, 15 minutes for this meeting. Thanks a lot.
Just to add to your question, I think the voice to text, which is getting really good now, at least there are now 3-4 different providers, they're brilliant. Whatever you say, it's there on your EMR. It filters off whatever is unnecessary also. It is so brilliant. Like let's say you're starting to talk in Hindi to somebody bringing you chai. It's not there. Okay? You're starting to talk in Telugu somewhere in between with somebody. It's not there. Whatever you're saying about eye, the cornea is clear, the lens MC, immature, cataract, PSCC, probably it's a PPC, I need to do an AIOS2025, and then whatever you say is there on the EMR. I mean, that's the way AI is going. See, I think the problem with the EMR is how it is designed and how comfortable it is to use, and that is the big problem now, people. That is why we're not able to enforce, at least even in the doctor's level itself. In many places I've seen, finally they have a technician entering all the information from a paper. But somewhere you need to force them to use EMR, but with the AI technology, I think you can take it to the next level.
Even the Excel does a very good job. You don't have to have a professional EMR. Most of the things, in fact, a few years back, the 2020 resource from urban side was based on Excel. It was pretty good.
Yeah.
And it does 90% of the job what a professional EMR, which you will pay as a service or whatever, or you own it. Excel does it pretty well. We have to understand that EMR should complement us. I mean, it should not be that we are putting in data and not talking to the patient. Or your staff is putting the data and not talking to the patient. And as RDR sir said, that AI is going to come very close. So what is going to make a difference is experience or empathy or that human touch.
Thanks a lot. Thank you.
You can even make an EMR using Grok.
Yeah.
I went on Grok and I gave a prompt.
Yes.
Can you write a So it wrote that, basic EMR. Then the next prompt I gave is, I'm a novice software developer, I don't know. Can you tell me how to implement it? It gave exactly all the steps, which software to download, where to put this code that it has given. I did that, and I found that I had a functioning EMR that I could use.
Correct,
The
correct.
only thing is the interface for data entry, it says that you need somebody to create that interface, which makes it easier for you to, otherwise it's like a software, like an Excel sheet that you have to put.
Correct,
But
exactly.
I'm telling you that the way things are moving, a lot of things you can do even without knowing what to do.
True, true, true. So there won't be any difference between the first year resident joining the AIMS and Dr. Vanathy, no? There will not be any difference. So, thanks a lot.